So welcome everyone. Thank you for joining us for this webinar about systemic juvenile idiopathic arthritis, or sJIA. My name is Richard Beasley and I'm the founder and director of Juvenile Arthritis Research, which is a charity and patient organisation within the UK. And I'm absolutely delighted to be able to co-host this today with my colleague Wendy. If you ever need any support from the organisation, from our charity, please do visit our website at jarproject.org/hope, and we'll do everything we can to support you. Wendy, would you like to introduce yourself?
Thanks, Richard. Hi to everybody today. So I'm Wendy Costello. I have a daughter who's got JIA. She's now 25. She was diagnosed at 3. And I set up a charity in Ireland called ICAN, the Irish Children's Arthritis Network. But I was really lucky to meet Richard at a European level. We were both on an organisation which supports children with JIA, sJIA and auto-inflammatory diseases. And I now dedicate my time to helping Richard and volunteering for him, which I'm delighted to do. And that's a little bit about me.
Thank you, Wendy. And today our main presentation will be given by Professor Paul Brogan. Paul is a professor of vasculitis at the University College London in the Department of Infection, Immunity and Inflammation, and is an honorary consultant at Great Ormond Street Hospital in London. And Paul will be giving a presentation in a few minutes about the important signs and symptoms to look out for when you have a child with systemic JIA. What you need to know is when you're first starting out on this journey, and some useful hints and tips, and also hoping to answer some questions that we've been sent in. At the start of this, we thought it was really important to hear from a family, and we're really grateful to Arthur and his mum for sharing a little bit about their journey. So I'm going to share a video with you now, and I'll say we're very grateful to Arthur and his mum for sharing this with us.
Hello. My name is Arthur Coward. I'm 12 years old and I have systemic juvenile idiopathic arthritis.
And I'm Victoria and I am Arthur's mum. And we're going to tell you a little bit about Arthur's journey with sJIA in the past few months. So Arthur started to feel very unwell in September last year?
August.
He was very tired. And he had a lot of pain in his legs, in his back. It moved to his shoulders, and we were concerned. So we went to the doctors, and initially it was treated as a pulled muscle. Following that, we just treated it like a pulled muscle, and we hoped it would get better. But Arthur continued to be very much in pain. He lost weight and we were very worried about him, so we took him to the hospital, where he went and was looked at by the fracture clinic. They were concerned that perhaps he had fractured his leg. The fracture clinic doctor said there was definitely no fracture, but advised us to go and see the GP as soon as possible. When we got to the GP, they did blood tests, and the GP noted that Arthur had lost a lot of weight. He had some quite bad arthritis in his knees, ankles, shoulders, down his spine, in his elbows, everywhere pretty much. He was incredibly fatigued. He'd lost all of his appetite. So when the blood tests came back, they sent us to the child assessment unit for an urgent assessment at East Surrey Hospital. We remained in East Surrey for quite some time. How long was it? Just over a week, was it? And eventually East Surrey, after a lot of tests, transferred us up to London to the Evelina.
For a week and a half.
For a week and a half. Where we had a lot more tests, and eventually Arthur's hemoglobin dropped so low they were unable to bring it back up. He had to have a blood transfusion. He was still very, very poorly. The doctors wanted to hold off to start a treatment until they were sure about the diagnosis, but they couldn't be sure. So they started Arthur on a steroid transfusion, and then after that sent us home. We had at that point a working diagnosis of sJIA, and we were just told to see how the steroids went, which we did until just after Christmas, when we were started on methotrexate. The methotrexate failed fairly quickly. After about 10 weeks, Arthur had 2 flares in that time, the second of which was really quite bad, and his blood started to go down again. And we've now been offered the chance to try TOC, a biologic drug, and we started that at the Evelina this week, didn't we? We went up on Wednesday. You had your first infusion. We still have just a working diagnosis of sJIA, but the consultant has said there really isn't anything else that it could be. And so we have had not a huge amount of information given to us, still, even at this point, about what sJIA is, what we should do, what we shouldn't do. So we are really keen to help JAR in this project to help get better information to parents, particularly at diagnosis. That would have really helped us, wouldn't it?
Yeah.
And yeah, thank you very much.
Brilliant. Thank you, Victoria and Arthur, for recording that and sending it over for us. Wendy.
I think that set the scene really well. I know me and Richard are always big advocates to start anything that we do with the patient perspective first, and no disrespect to Paul, I'm sure he totally agrees that's always a great way to start. But I'll hand over to Paul now. I've been lucky to hear Paul on numerous occasions talk. He talks not only to a high level crowd of clinicians and researchers, but he makes it very user friendly for us patients. So I'm delighted to welcome him here today. Paul, thank you for giving up your time.
Thanks, Wendy and Richard. Let's just see if we can pass the first test of sharing the screen. If I do that, and then I do that, can you see my PowerPoint there? Someone say yes?
Yes, we can.
Perfect. Okay, folks. Well, look, thanks very much for asking me to give this talk. Hopefully, I mean, the interest was very clear from the sheer number of questions that were sent prior to this presentation. So I made the presentation before I saw the questions, but I think that the presentation will probably answer most of them straight off. And at the end of this, I hope as patients you can get as irritated with the system as I currently am, because I think you have some important messages that you need to start lobbying for as patients, because we as clinicians so far have failed, and I'll explain what I mean by that in just a minute. One of the first questions was, what do we call this disease? Is it sJIA or is it Still's disease? Well, it's both, is the official answer. I prefer Still's disease because it is the same disease as adult onset Still's disease, and George Frederick Still first described the condition in children. And you don't need to have arthritis at the beginning in order to make the diagnosis. So I prefer Still's disease for that reason. So there's the first question answered, hopefully. So this is a complex systemic auto-inflammatory disorder. So you don't need an infection to trigger it off. The body can automatically make the inflammation. And it's really quite distinct from other forms of juvenile idiopathic arthritis, or JIA, because of its prominent systemic inflammatory features. So systemic means inflammation throughout the body and found on blood tests. I'm going to use a few medical terms, not to bamboozle you, but to try and educate you, so that when you experience these words in a medical context for your child, you'll be able to refer back to them. But I'll define them as we go, and if there's any medical words that I use, just put it into the chat, and we'll answer them at the end. So historically, this was known as Still's disease after George Frederick Still, who was actually a paediatrician at Great Ormond Street. who described the disease in 1897. And it's classified alongside other forms of GI, but it's a bit different. The ILR criteria are the International League Against Rheumatism. So it's a bunch of international experts that get together every 20 or so years. And more recently, there's been a move towards calling it Still's disease for the reasons that I've mentioned to you, away from sJIA. So I prefer Still's, but the official line is sJIA or Still's. So the clinical presentation can be a bit non-specific at first because your child will present with fever, and it's a high spiking fever. And there's a funny word us doctors like to use, quotidian, which means daily, or biquotidian, twice a day. I don't know why you just don't say daily or twice daily, but it's a spiking fever is what the textbooks will tell you. But when the child first presents, it can be a very hectic, non-spiking fever, a bit like when you have infection. Then you only really need to have 3 days of the spiking fever to satisfy this sort of classification criteria. This is perhaps not the best example, but you see the spikes here. But what we also look for is the temperature going below the normal temperature when the fever is all sometimes down to 34 or even lower. So a spiking fever once or twice a day that can go below the normal temperature when it settles. And here's the really important point. Arthritis is not always present. You heard the story from Arthur, where at least there was arthritis to provide doctors a clue to the diagnosis. But quite often, there's no arthritis, and the arthritis may not appear for many weeks or even months. There's a salmon pink rash shown here, and this is a patient who's been scratching their rash. You can almost see the linear scratches because the rash can be itchy as well, and it's often mislabeled as a viral rash, or some patients don't even recognize it as a rash. We say, has there been any rashes? They say no, but we've had this redness on the skin. Well, that's a rash. And it's given another fancy name. It's called evanescent, which basically means it comes and goes with the fever. And it can be very nondescript, particularly if you have darker skin. You may not even notice this as a rash. Swollen lymph glands can be very typical, and if the doctor examines the child, there may be enlarged liver and spleen as well. And sometimes that makes doctors worry about either infection or cancer, such as leukemia, when the child first presents. And there's a high risk for development of this funny term called macrophage activation syndrome. And I've put in brackets the other term that you probably have heard of in the context of the pandemic, this cytokine storm. And for all intents and purposes, there were many features during the COVID pandemic of the very severe manifestation of cytokine storm with the macrophage activation syndrome. Hence, it's probably not surprising that many of the treatments that were used during the pandemic actually came from rheumatology and from us pediatricians who were used to be looking after the macrophage activation syndrome. This is a funny picture here. It's not that doctors are bad at drawing. It's called a homunculus, and it's meant to provide an indication of the joints. As you can see, there's some red joints here indicating that arthritis can be present, but it's not always. So for all intents and purposes, there are 2 phases of sJIA. And the idea is that there may be a window of opportunity that if you get in early with the right treatment, you may prevent progressing to a more chronic form of arthritis shown here. That's the idea, but I'm going to show you some data that really questions that. So there's an early so-called auto-inflammatory phase. So that's when you have fevers and the rashes with or without arthritis. And probably it's driven mainly by this inflammatory hormone in the body called interleukin-1 or IL-1. So this is the phase when the children gets the fever, the rash, maybe the arthritis, but it can be absent. And also the first presentation might be with this catastrophic inflammation called the macrophage activation syndrome. And I'll tell you a bit more about that in the end. And then if you get in early with really the only blocker of IL-1 that's available in the UK for this indication, anakinra, the idea is you may help prevent progression to a more chronic or prolonged form of inflammation driven by another inflammatory hormone called interleukin-6 and another one called interleukin-17. And in this phase of the disease, the arthritis is more common, and sometimes the fever and the rash abates, but more often than not, the arthritis carries on alongside the fever, the rash, and if the doctor does a blood test, the very abnormal levels of inflammation in the blood. So the window of opportunity that you'll often hear about on the internet refers to getting in early with the right treatment to prevent the disease becoming more prolonged. So these are the trials that have been done in sJIA over the years. A thumbs up means that it works, and a thumbs down means it's been done and it actually didn't work. And so the first trial was done by Pat Wu. It was a mixture of patients with oligoarticular JIA and also systemic JIA, and it was in relation to methotrexate. So it's a yellow dot shown here. Let me get my little pointer. Yellow dot and then yellow in methotrexate. And in fact, what that showed was for the subgroup of patients who have systemic GI is that methotrexate did not work for the systemic features. So this is a randomized controlled trial showing that methotrexate did not work for this disease. Now, many clinicians will say, well, we do use it when there's just the joints. Sure, you can use it at any point for the joints and it may or may not work, but it does not work for those patients who have got fevers and rash. So I was not surprised to hear Arthur's story where after 10 weeks, really this treatment did not work, because that's what the clinical trials would have suggested would have happened. And that trial was published in 2000. So then as we go along, there was a small trial of anakinra from the French group. It was a randomized controlled trial of about 20 or 30 patients, and it showed that anakinra, which is the main blocker of IL-1 that's available in the UK for this indication, did work for sJIA. So that gets a thumbs up. And then we start hitting the TENDER trial, which was published in the New England Journal of Medicine, and soon after that the canakinumab trial. In fact, I think they were in the same edition of the New England Journal of Medicine, that showed that patients with Still's disease or sJIA really did respond to either tocilizumab, which blocks the inflammatory hormone IL-6, or canakinumab, which is a more expensive version of a medicine that blocks IL-1, so doing the same thing as anakinra. And then really nothing published until we took part in some trials in the early 20s, which was eventually published last year, for a medicine called emapalumab, which was in relation to emapalumab as a medicine that blocks another inflammatory hormone called gamma interferon, which is the main inflammatory hormone involved in the macrophage activation syndrome. So this trial that got a thumbs up showed that emapalumab seemed to be a good treatment and a good targeted treatment for MAS if you have Still's disease. And then in amongst all of this changing therapeutic landscape, we had the so-called interim NHS clinical commissioning policy. And I put interim in inverted commas because it's not been updated since. And in fact, it really was first drafted in about 2014, but I think ultimately published in 2015. So there's the evidence. Methotrexate doesn't work. All these other biologics did seem to work, and we've even begun to get treatments for MAS. So what does that policy tell us that we can do? Well, here's the bit that you should get cross about. Methotrexate is the first line DMARD. So DMARD is a funny abbreviation. It stands for disease modifying anti-rheumatic drugs. And despite the clinical trial showing that it did not work for sJIA for the systemic features, that's what you've got to fail in the UK as a child before you're allowed to get access to a biologic. With one exception, anakinra. If your doctor feels that there are features of macrophage activation syndrome, then you can start with anakinra, only with that caveat. Otherwise, the indications for biologic use are if you are intolerant to methotrexate, so sickness, etc., or if you have failed methotrexate treatment, as Arthur's story had shown. And so at least for children, you only have to fail one treatment that's been proven not to work. But for adults, there are two DMARDs, disease-modifying anti-rheumatic drugs, that need to be failed. So the situation is even worse for adults. So I feel quite strongly that AOSD, adult onset Still's disease, is the same as Still's disease, and you can extrapolate from the pediatric trials to show that methotrexate and things like that would be anticipated to fail. So if you do fail methotrexate, the only other biologic really you've got access to is tocilizumab at that point. Canakinumab, proven to work, has now failed 2 NHS policy proposals purely because of the cost. So On the background of that changing therapeutic landscape, we tried to see what we had been doing at Great Ormond Street and opportunistically try and have a little look, without doing a clinical trial, retrospectively, about whether outcomes were any different for those patients who received early biologics within the first 3 months versus those who really stuck with the policy and got their biologic much later. And part of that was driven by the policy, and part of that was driven by clinical practice going back to 2005. So the objectives of this GOSH review was to just, what did the children present with, how many had arthritis, how many didn't, what treatment did they receive, and what was the longer term, shorter term and longer term outcome. And this work was published last year in Frontiers in Pediatrics. You can all access that if you click on. I know that this is being recorded, so you can follow that link. Charlene Foley, who was one of our registrars at the time, now working at the Evelina, was the first author of that paper. So there were 76 patients with sJIA, Still's disease, at Great Ormond Street. You can see that at presentation, so this is when the children first presented, fever and rash and inflammation on blood tests was present on 100%. And the arthritis was only present in 80%. So 1 in 5 of the children didn't have arthritis. And in fact, 36, so just over a third of the patients, actually presented with features that the clinician was worried about, the macrophage activation syndrome, as their first presentation. So this is the treatment that the patients received. And again, this is driven mainly because of the changing therapeutic landscape and clinical practice spanning this, 2005 to 2021, i.e. 16 years. So glucocorticoids, otherwise known as steroids, virtually all the patients had received steroids, 92%. And nearly half received methotrexate as their first DMARD. Anakinra was used in about 28%, and tocilizumab only in about 8%. By the time the last review came, at a median time of about close to 5 years, 8% were still on steroids, 11% were still on methotrexate, and that's probably because of chronic arthritis. About a quarter were on anakinra, a quarter were on tocilizumab, but of the patients over those 4 or 5 years of long-term follow-up, 84% had eventually needed a biologic in any case. So even though they might not have got it in the first 3 months, by their last follow-up, they all had proven themselves worthy of a biologic according to the NHS rules and ended up on one. In terms of the treatment response, let's just focus in on this for clinically inactive disease. So that means the clinician has given you a score of 0 out of 10. The patient agrees it's 0 out of 10, but we're not saying anything about whether they were still on treatment or not. And in fact, at the last follow-up, 88% of patients had clinically inactive disease. So for a disease that had really a very poor outcome 25 years ago, that's not bad. 88% clinically inactive disease at last follow-up. In terms of glucocorticoid-free clinically active disease, again, excellent news. 84% had their clinically inactive disease and were free of steroids. So that's fantastic. But only about a third of patients were actually in remission, by which we mean clinically inactive disease and off all treatment. So we can say that this is a disease, at least the ones that presented to Great Ormond Street, that at least in a third of patients requires, in 2/3 of cases, requires treatment for the longer term, and only a third of patients will get off treatment at their last follow-up after about 5 years. So we're then able to try and dig in to see, of those patients who'd received a biologic, mainly anakinra, in the first 3 months, did that make any difference to their longer term outcomes? And in fact, it did. The use of anakinra in the first 3 months results in better outcomes at 1 year. And remember, this would have been heavily weighted to the more severe patients who presented with the macrophage activation syndrome, or at least a suspicion of. In other words, the clinician could access that treatment. Because at the 1 year review, inactive disease was achieved in a greater proportion of those treated with anakinra in the first 3 months. And it wasn't just a wee difference, it was a big difference. 90% versus 53%. That p-value, that means it was, the smaller that number is, the more statistically significant it was. So that was highly statistically significant and also quite important, 90% versus 53%. In addition, there was a higher rate of patients coming off steroids by 1 year if you'd received your anakinra within the first 3 months, 69% versus 47%. And whilst this is numerically important to you as patients, it did not reach statistical significance. And then by the last review, this was a bit interesting to us. High rates of inactive disease were achieved irrespective of the timing of the biologic initiation. So there was nothing magic about giving the treatment anakinra in the first 3 months. It's not as if it was, you know, shining this window of opportunity and saying you're going to be completely, absolutely fine. All the patients caught up at the last review with early anakinra 90% having clinically inactive disease versus 86% of those who'd received the anakinra a bit later. So what we can conclude is that this doesn't necessarily support a window of opportunity, but what it does say, it makes a lot of sense to get an evidence-based treatment proven to work sooner rather than later. In terms of complications, over time, although 36% had presented with the macrophage activation syndrome, or at least suspected, and that's an important point, by the time of the last follow-up, that number had increased to 46%, so just under half. The treatments that those patients had received were steroids, anakinra, cyclosporin, etoposide, one of the more severe treatments, chemotherapy treatments, and a couple of patients actually were in the emapalumab trial that was running at the time, or over the study follow-up period. Only 4 patients of the 76 needed to progress to a bone marrow transplant, and all achieved clinically inactive disease. In terms of lung disease, only 1 patient, or 1%, was found to have the lung disease, and we definitely conclude from that that in our series over that period of time it was underdiagnosed because patients were not having as routine a CT scan of their chest, which is what they need to make that diagnosis, because the clinical features can be completely hidden. Here's a good bit of news. No patients died during the study period. However, 1 patient did die from MAS 7 months after the data collection was completed. So we felt it was important to report that, even though it was out with the study time, because it emphasised that the macrophage activation syndrome is this most serious complication of sJIA. So what about this macrophage activation syndrome? How does that differ from the presentation? Well, as you can see, about 1/3 of patients may have some features reminiscent of MS when they first present, but your child may already be diagnosed with the systemic GIA and then have a fever that maybe some other family members have gotten a cough and a cold, but in that child goes on a bit more and it doesn't settle, and the blood tests become more inflammatory, and 10 days later you're on 10 days of antibiotics and it's still not settling. And eventually someone will do a blood test and find very high degrees of inflammation. And a ferritin, someone may have recommended, and would find that to be high, over 400. And that should be a clue at that point. This is now what we call a host response. It's not just driven by this infection that the other family members had. It may be the macrophage activation syndrome. And what's happening to the patient at an immunological level is the flavour of inflammation is changing. So I've told you that IL-1 is elevated as an inflammatory hormone early on. Later, IL-6, maybe IL-17. But then, for whatever reason, the body starts churning out lots of gamma interferon. That may be triggered by a viral infection or even a bacterial infection. It may be triggered by a change of medication, or it may happen all by itself, and as doctors don't know why some patients will suddenly switch to that pattern of inflammation. But it drives a particular flavour of inflammation that we've referred to as hyperferritinemic inflammation, basically just describing this high ferritin. And that a clinician should be recognizing this early and not waiting to tick all the boxes to fulfill the diagnosis. So the full box ticking exercise waits for your child to have very abnormal liver function or liver failure, abnormal clotting, for the hemoglobin to drop, for the platelets to drop, etc., etc. We try and teach your juniors not to wait for that and to be aware of hyperferritinemic inflammation and jump on that early with high doses of steroids and anakinra. So there's the first treatment, methylprednisolone, high dose pulses, 30 milligrams per kilogram, maximum a gram, 3 days in a row. anakinra, cyclosporin, and hopefully in the future, outside of clinical trials, if it gets licensed, emapalumab. Other treatments I've mentioned to you, etoposide, are less commonly used, and that's good news because they're more toxic. So in summary, from our experience, overall, we can tell you some good news that the Still's disease outcome is good, with 88% achieving clinically inactive disease with modern treatments, and 84% of the patients being free of steroids, 32% being in remission, i.e. quiet disease, and no treatment whatsoever. That we think that if you get in early with biologic treatment, mainly anakinra, less than or equal to 3 months, you get a significantly better outcome at 1 year, but there's no difference in the longer term outcomes at final follow-up, i.e. if you don't get your biologic early but you eventually do get started, you'll have the same longer term outcome in our hands as the patients who received it early. So the take-home messages that we published at the time was that the early use of anakinra, tocilizumab, or canakinumab is logical and evidence-based. It's highly efficacious. It's totally safe. It needs monitoring, but it's safe, and it's actually, we argue, cost-saving for the NHS because it is cheaper to treat a rare disease correctly first time round rather than wait for methotrexate and other treatments to fail, is what we say. And so in that publication, we said you really need an overhaul of this interim pathway, and a new therapeutic pathway for sJIA in the UK is urgently needed. And in fact, the same for adult onset Still's disease. So we propose this. Firstly, make the diagnosis. Call it Still's because it de-emphasizes the need for arthritis to make the diagnosis. We say give anakinra up front. Be liberal with your doses, 2 to 8 milligrams per kilogram per day. Usual maximum dose of 100, and usually given with glucocorticoids. Or some in the Dutch group are being brave and just giving anakinra. We've done that in 1 or 2 patients, but still, to my mind, you need a bit of steroid on board. But it can be much reduced. So prednisolone or IV methylprednisolone. I don't mind if you also give methotrexate on top of that, because that can be good for very active disease. But to be honest with you, I would start with anakinra and steroids, and then reassess after 3 months as you wean the steroids. If you've still got active disease, you can at that point switch to either subcutaneous or intravenous tocilizumab, which blocks IL-6, and again, reassess after 3 months and ask yourself at that point, are there systemic features? And that means fevers and or rashes and or inflammation on blood tests. There may be active arthritis, but we're looking for the systemic features. If the answer is yes, at that point we would like to switch to canakinumab, but in the UK you're not allowed to for this indication. Or consider another biologic, but really there's very poor evidence at that point. So then usually what we do, we would have to add an old-fashioned medicine, cyclosporin, which can be given by mouth. And if that fails, you kind of fall off a cliff face, because we'd like to give other treatments like baricitinib or get them into a clinical trial, but the NHS will not allow that. So you're really looking at that point at a bone marrow transplant, and that's hematopoietic stem cell transplant. And the word allogeneic there is included because we do not endorse anymore having the bone marrow from the own child, the same bone marrow, which is what used to happen. It needs to be from a matched donor. If you have got active, if you come down at 3 months after failing tocilizumab and there are no systemic features, at that point you can add methotrexate for active arthritis if not on already, because you may have started that already if the joints are hot and active, or you could switch to anti-TNF as per normal forms of arthritis, i.e. non-systemic, and then reassess. So you can see quite quickly that you run out of options by the time you fail anakinra or tocilizumab in the UK. And what I think the patients should be up in arms about is the lack of access to canakinumab despite the excellent clinical trials. So I'm going to stop there, I think, and hopefully that's answered some of your questions, and I'm sure there'll be other questions that I'm happy to try and answer to the best of my ability.
Thank you, Paul. That was really interesting, and really appreciate you running through all of that. I've been busy scribbling down lots of notes, and I'm sure that lots of people were watching this both live and later on are going to have lots of messages, and I'm certainly going to be rewatching it and trying to capture everything. We have had, as you mentioned, quite a lot of questions in advance. And if anyone's watching this live and has any more, then please pop them in the chat. We'll try and get through as many as we can. We can't give specific medical advice about your own child's situation, but we'll try and cover in general terms about the sort of advice you need to consider. And so the first question, so Wendy and I are going to take these one at a time each, I think, to fire at you, Paul. So the first question we had in is, if my child enters into remission, what are the chances of their still flaring again? And if they do flare, is there anything they can do to prevent him being so ill the next time round?
Well, from our data, the answer is 2/3. So this is not a disease that burns itself out, and it doesn't stop being systemic juvenile idiopathic arthritis when you're no longer a juvenile. It's the same disease all the way through. And I always tell the patients that you can have long-term remission. And you saw from our data, we can put some numbers to it now. A third of the patients at 4.7 years follow-up were in remission, by which I mean off treatment and disease-free, but 2/3 were not. And if you enter remission, you can relapse, and it may be many, many years down the line. It can be triggered by an infection, or it can happen all by itself. And there are really no biomarkers. Biomarkers means a blood test or a fancy clinical sign or an x-ray or anything like that can tell you that you're either at risk of relapsing or that you have relapsed. So it's just recognition. It's back to the beginning. It's resetting the clock. Fevers, rash, abnormal blood tests. So it's just that simple bit of human knowledge that this disease does not burn itself out, which is what used to be taught to medical students many years ago. If you know that as a parent, you know what to look out for. And if you're then a young adult whose mum and dad may not be around to remember to tell them, it's important that the adolescent or young adult remembers that they have this diagnosis, and it's not gone away just because they've become a young adult.
I think the next question is more or less the same, Paul. If a child has suffered a mass event, even if only early stage in the past, are they more likely to suffer another in the future?
We don't know, but my own impression is probably. You know, if you've proven yourself to be able to deliver that flavor of inflammation in the past, then it's entirely possible that you could. And certainly some patients have what's regarded as relapsing mass. Funnily enough, that when you get into it, it's mass that really has never gone away. It's more like smoldering mass, that some of the abnormal blood tests are a lot better, and you may be off the very severe treatments and could go home, but they're not quite normal. And so we now know that when you measure an inflammatory hormone in the blood called IL-18. Some patients have sky-high IL-18, interleukin-18 levels, even when their mass is in remission. And I think it's those ones that may be at risk of the relapsing disease. But that biomarker has only recently become available at GOSH, and it's certainly not been proven to be able to be used by patients to predict if they're going to have a relapsing course or not. But watch this space.
And just, sorry, Richard, just coming on from the video we had beforehand and discussion on mass, I know obviously it's not when you get a child first and you suspect a diagnosis of sJIA. I know you don't as a clinician, and lots don't want to frighten them and mention mass. So is this something that should be discussed with a family when they come in the first 2 or 3 appointments, even if you don't think it's going to be a problem, but just in case it did pop up? Or would you like to just see how things develop?
You have to always put yourself in the position of the parent. So there's sort of the risk of terrifying patients at the beginning, and giving them too much information and overloading them, versus giving them no information at all. So I can only say what I would prefer to have if I was a patient. I'd like to have the knowledge. I think patients are an informed group. They look things up on the internet. If the doctor doesn't mention it, they're only going to go home and find it on a dodgy website anyway. So it's probably better just to mention. And I think probably the population as a whole has been better educated about cytokine storm because of the pandemic. So you can say, look, it's a bit like during that pandemic, some patients can get a really bad form of inflammation. That's called MES for short, and we'll warn them about that. And these are the things to look out for. And if there's one blood test that the patient or the parent can be advocating for, is a ferritin. Get a ferritin and measure it every day and act on that ferritin.
Thank you.
Brilliant. Thank you, Paul. The next question is from another parent who's asked whether Children whose onset of sJIA or stills is a little bit later, so when they're a teenager, do they have the same chance of achieving remission as anyone whose sJIA starts when they're younger?
I think the patients who start very young, under the age of 2, and who have a very severe macrophage activation syndrome, I think they have a much worse long-term outcome for future episodes of MAS and also for the lung disease. We know that being under the age of 2 and having MAS as the first presentation are probably the most important risk factors for developing the lung disease. It's hard to say whether you're going to have a better long-term outcome if you're age 16. For a rare disease, there's not been that epidemiology done, but certainly we can say if you're very young, you seem to have a bigger dose of the disease, is what has been my experience.
Thank you. And there's a follow-up to that. You mentioned in your presentation about lung disease, and we had a question in about whether you think all children should have access to a regular CT chest scan or diagnostic tests to see if they're developing any form of lung disease, and if so, how can we push for that?
Well, sadly, I think we do need to be doing more CT scans. I can't say regular scans because there's a big dose of radiation, but for the very young children, it's really the only biomarker that we've got to diagnose the lung disease, and secondly, to monitor it. So I'm looking after a very young child at the moment whose only feature of the lung disease was when their fingers became swollen at the end, and that's called clubbing. They were not short of breath. They were able to toddle about and be a toddler. We knew that they had smouldering mass, but as soon as I saw the fingers, I did the CT scan. The parents couldn't believe it, and the scan was grossly abnormal. Now, if it was a bigger child, we'd be able to follow up on that and do lung function tests, where they do a breathing. That's a non-invasive test, but you have to be able to do the actual breathing part of that. So for young toddlers, and really until the age of 6 or 7, they can't really do lung function very easily. So then you're resigned to getting that fine balance between a high radiation dose for a CT. It's better than it was, but it's still a radiation dose to monitor the sJIA lung disease and its response to treatment. So definitely, gosh, over the years, we had not been doing enough CT scans for sJIA because we didn't know to. And over the past few years, we certainly have woken up to that. And so I do them now at diagnosis and then take it from there about how frequently you need to repeat that.
And just from a parent's point of view, my daughter was diagnosed at 3. And when she does talks at a lot of our family events, and she meets lots of kids who have JIA, sJIA, a lot of autoinflammatory diseases, she says the benefit of being diagnosed so young for her was that she didn't really know any difference. Her life was always kind of about her JIA. And yet we'd lots of kids, a particular one is coming to my mind, who was diagnosed at 16 with sJIA, who was a netball player and who was really upset at being diagnosed with this disease at that age. Whereas Niamh just breezed through life and just didn't know any difference, which I always think that's just something to think about as parents. Now, the next question for you, Paul, is long-term effects of being on Ilaris.
Absolutely fine. The canakinumab, even though it's not got any indication for sJIA in the UK, in fact, I've been using it for many, many years for a genetic disease called cryopyrinopathy. That's sometimes called Muckle-Wells syndrome, and it's a super safe medication of all the biologics that I use. That's the one that gives me the least trouble in terms of any idiosyncratic reactions, infections, etc. So I'm really not concerned at all about the long-term effects of IL-1 blockade. Look, there's no free lunch. You'd rather not be on it, but I think really I can reassure you about that one, based on our experience with other patients who've got a genetic form of autoinflammation called CAPS.
Thank you, Paul. I think you've covered this next one, but just to clarify, have you known children who have sJIA, a diagnosis, to then after that initial diagnosis only get the rash? So it doesn't develop into any other systemic features. It doesn't develop into mass. They don't develop the arthritis. It's just the rash, and then it's gone after that initial treatment.
Yes, I do have that situation, and it can often be patients who have been treated already for their sJIA, And then the only feature that's there, oh, I still got this rash that's coming and going. And that's really telling me that the disease is not completely in clinical remission, that your treatment has not been effective enough. So even if the rash is not causing too many problems, those are the patients I'm thinking of switching if they're on IL-1 blockade to tocilizumab, or if they're on tocilizumab to IL-1 blockade, because the rash is telling you about a process that's not completely switched off.
And then I know you covered a lot of the projects that have been happening for the last 10, 15 years, but someone just wants to know, are there any current or active research projects at the moment into the cause, presentation or treatment of sJIA?
Yeah, there are. I looked this one up to make sure that I had a complete list. So it's always good to give patients a generic, empower them. So you can all use the computer. If you put into Google clinicaltrials.gov, you come onto this website. It's a sort of worldwide type thing, and you've got a little search icon. You put in sJIA, it comes up with all the trials that have ever been done worldwide, because they all have to be registered on this website. And if you do that, you can apply a filter that says just the ones that are still recruiting, and then you can search by location. You can do all sorts of filters. So if you do that, there's 2 trials in the UK for children. One is for a medicine called sarilumab. It's just another Me Too tocilizumab. So in terms of what it's purporting to do, it's not very exciting. It's not like an uber duper new drug. It's just going to be, if anything, as good as tocilizumab. So it's what we call a Me Too study. So hey, sarilumab, Me Too, tocilizumab. And then there's one for a medicine that I am more excited about. It's called baricitinib. It's one of the JAK inhibitors. So that's currently open according to clinicaltrials.gov for recruitment in the UK. The SOBI trial of emapalumab for MAS, there were 2 diseases including for that. So that emapalumab is the medicine that blocks gamma interferon, the inflammatory hormone that's involved in macrophage activation syndrome. And macrophage activation syndrome can happen in Still's disease, but it can also happen in lupus. In fact, that trial is closed for MAS caused by Still's disease, but remains open if your child has got lupus. So it's not really open for Still's disease anymore.
Sure. One of the treatments you've mentioned is steroids, and we all know that there's issues with or complications with steroids, or can be. So one of the parents on the call would like to know if long-term steroid use always results in complications, or whether it's as with other things, sometimes you might have complications, sometimes you won't.
Yeah, so it's an excellent question. It hits at the heart of the matter. So steroids are the most potent anti-inflammatory medicine available in medicine, and have been for the last 80 years since they were first used. And despite all of the advances in clinical science, steroids remain a super life-saving treatment, and there's definitely no free lunch. So you need to give as much steroid as needed, but at the lowest dose and for the lowest duration. And so the idea is that you keep moving on the steroid, you keep weaning the steroid once you've gained some semblance of disease control, and that will minimize side effects. Virtually all patients will get some degree of side effect. Most of them are reversible as the steroid is weaned off and comes down. And we know this because we've now done quite a bit of work in developing a tool to actually document steroid toxicity called the Pediatric Glucocorticoid Toxicity Index. And that's the sort of tool that you use in a clinical trial to capture steroid side effects. And there are 2 types of side effects. There are damage items that once you've developed them, that's it. There's no coming back from it. So if you develop a cataract, that's it. That cataract will always be there, and until it's either repaired or needs to be removed, you will always have that. If you have severe stretch marks, they will always be there. They don't go away. So the good news is that they may be very red initially, but then they can go paler. And then the last damage item that once you develop it is always there is if you have an avascular necrosis, for example, of the femoral head. So that all sounds terrible and depressing, but on the whole, most pediatric patients do not develop those. They might get weight gain, they might get some sleep disturbance, behavioral problems, but these are all reversible as steroids are weaned and eventually stopped. You can have some patients who may be on a smidgen of prednisolone, maybe 5 milligrams daily, who seem absolutely fine with minimal side effects, and answer specifically to the question. But the idea is you really try and get patients off steroids as soon as you can. but they ain't gone away yet. The steroid-free treatment does not yet exist, despite many doctors aspiring to that.
Thank you. I will just add to that, and I'm sure with your clinical hat on, you'd agree that if anyone is concerned about medication, speak to your clinical team, and certainly don't just stop, particularly steroids, don't just stop straight away. Speak to your clinical team, because there is a process for going through that to make sure it's as safe and effective as possible.
That's right. If you stop steroids suddenly, you can have what's called an adrenocortical crisis, where the child will be puking, have a low blood pressure, not feel very well. So you've got to be careful.
And the next question, Paul, is I'm interested in treatment pathways, and why were we directed down the intravenous steroid treatment pathway?
Well, I don't know about the specific case, but intravenous steroids can be absolutely life-saving. So you'll see on the flow diagram that I showed, you've got the option of giving high-dose pulses of methylprednisolone. The rationale behind it, the way that high doses of steroids and also oral prednisolone works, is it causes death of some of the white cells that are potentially causing the trouble, and then they bounce back about 5 days later. So if you give 3 days in a row of high-dose intravenous, you may be able to switch off the disease process by causing what's called apoptosis of those offending white blood cells. And then as they grow back about 7 days later, it's called rebound, you need to give another 3 pulses. And the idea is that if you do it in that way, firstly, it can gain very rapid disease control, which is essential if you're developing macrophage activation syndrome. But the other thing that some people forget is that the idea is if you give pulses, you may be able to go in at a lower dose of daily prednisolone in between. And what I've seen some of the junior doctors doing, they give the pulse, and then, by the way, they're carrying on with a high dose anyway. So sometimes that's needed, but just to remember that if you give pulses, you might be able to go in at a lower dose, maybe 0.5 milligram per kilogram of pred or 1 milligram per kilogram of daily pred, and you may be able to actually reduce steroid toxicity by giving the high doses up front.
Thank you, Paul. We've had a question in advance which sort of mirrors one that's just come in as well, which is the child is now been largely okay. They're in remission. They had a flare and developed mass at some point, and that's gone away. But they just want to know what they need to look out for. And you've mentioned in your presentation about those early indicators, the fever, the rash, and so on. Is it just a case that from this point on, if you've been diagnosed with sJIA or Stills, you need to just be aware that if you develop that fever or you develop a rash, then you need to be seeking the assistance of your medical team? Or is there anything else they need to just be aware of?
No, that's it. It's as simple as that. There's nothing super clever. You know, the doctors, they just need to remember that the child has got Still's disease, and that these types of flares can happen with an infection that may trigger it, or completely all by itself. It may have been diagnosed as an infection, but in fact wasn't all along. It was a fever and a rash because the disease was coming back all by itself. And patients, generally speaking, should be having, if they're on a biologic treatment, should be having a blood test every 3 months anyway. So if there's a blip in the bloods, C-reactive protein, CRP a bit high, ESR high, you know, that's the sort of thing you should be watching out for on the blood tests. But it's just as we said, fevers, rash, joints.
I think the next question is something that we probably all think about when our children are diagnosed. This child has been diagnosed at 21 months, so she's wondering about the preschool setting and nursery setting. Should she get a home nanny, because she's obviously worried about the risk of picking up infections?
No, the whole point of all of this is to give people's lives back. And you just don't have to look too far to history to know that if you socially isolate children because fear of infection, the actual health problems that can be caused by that are massive, i.e. The pandemic. So I would get them into school, treat them as normal children, is my advice.
Thank you. As a little plug for some of the support that juvenile arthritis research can provide, if you have a child going to school or preschool or nursery and you want information advice for them, we have we call them school toolkits, and they give some information about how to best effectively support your child in that setting so they can live a full, active, if you like, normal life in school. With whatever extra support they may or may not need, just making sure that the teaching staff and the school staff are aware of what your child needs in that setting. Question, Paul, from someone who sent a message in advance. can children with other forms of juvenile arthritis also develop MAS?
Yeah, probably they can. You would have to ask yourself the question: would it be the correct diagnosis? In other words, did they have sJIA all along? Is what I would be worrying about. One useful thing is that if what I always teach the juniors, that if there is no rash at the presentation, it's unlikely to be a true systemic JIA. And so it may have been that this was an sJIA right at the beginning, but the rash wasn't appreciated. So maybe clinicians hadn't been thinking about it, maybe labeled it as another form of arthritis. And then, by the way, you've got MAS. So if you develop MAS, I would be revising the primary diagnosis. Anything is possible. MAS is not just in the arena of Still's disease. You can get it in Kawasaki disease, another inflammatory disease. You can get it in SLE and other connective tissue diseases. So anything is possible, but it's just much more represented in sJIA.
I think we'll finish probably on this one, Richard. I think we're getting out of time, but this is actually an important one for lots of us parents. Are there any key messages for parents to tell local district hospitals if a child is flaring, or is the best advice always to contact your rheumatology team?
If the child is flaring or there's a concern, do the blood tests, measure the ferritin, phone a friend.
Thank you, Paul. That's a really nice way of finishing it. And thank you, as I say, for connecting with us today and presenting about sJIA, Still's disease, in children, and answering all these questions. We really do appreciate it, and I'm sure we're going to be in touch over the coming weeks and months to make sure we can make information available to parents as and when they need it to best support them. So thank you to everyone for joining us and for listening, and thank you particularly to Wendy, my co-host, and to Paul for taking the time out of your day to present with us. Thank you.
And thanks for all you do at JAR. It's important. I'm sure your patients who are part of it really appreciate your support.
Thank you.